To chair the session, we have Dr. Pratap Jetwani, who will be joining in some minutes, and Dr. Rutul. Dr. Rutul, the stage is yours.
Yeah. Thank you very much, Dr. Kirti. Very warm welcome to everyone for Diabetes India World Congress. It is 12th World Congress of Diabetes India and first day. This is a virtual day today. And for today's inaugural symposium, we have Dr. Vijay Neglur as our first speaker. And his topic is on beta cell preservation. Is it myth or fact? Dr. Vijay Neglur is MD General Medicine and Fellowship in Diabetes from UK. He is co-founder and medical director at Dr. Neglur's Diabetes and Thyroid Specialty Center, Thane. He is an honorary associate professor of medicine since last 20 years at Rajiv Gandhi Medical College and Shivaji Hospital, Kalwa, and he has served as MBBS examiner and convener for MUHS. He is currently one of the leading teachers in PHFI, that is Public Health Foundation of India, and currently teaches on variety of subjects like diabetes management, thyroid management, pregnancy diabetes, and cardiology and diabetes. He is on the advisory board of various Indian and international pharmaceutical companies. He has earned the title of Syndrome Man and Gentle Giant in Diabetes by his students and colleagues on account of his impressive diagnosis and treatment. His colleagues and teachers have given him a rather befitting title. We are privileged to have him here. Over to you, sir.
Thank you, Chairperson Dr. Rutul and Dr. Pratap for very, very kind words of introduction, and congratulations to Dr. Bansi and the entire team for putting up such a fantastic show of the Diabetes India, which is the IDF India. Just give me a minute to share my presentation.
Treatment, his colleagues and teachers have. Yes, sir.
Yes, okay. So I've been given the task to speak about beta cell preservation, myth or a fact, and I'll be restricting my talk due to paucity of time to only type 2 diabetes. So this is what we have, the natural history of diabetes. We know the insulin sensitivity starts coming down and stays stable. So this is the insulin resistance. As it sets in, we have a beta cell function which relentlessly tries to compensate the insulin resistance, and eventually a point comes where it breaks off. This happens in about 30% of patients, that it's no more effective in mounting the response against insulin resistance and starts failing. And at that point of time, you can see here the glucose starts rising. And as the glucose starts rising, you get all those vascular complications. This happens over the time of years to decades. And we all know that it is the Western diet and no exercise and obesity is the cause for the insulin resistance. And we have this beta cell compensation, which is supposed to mount the response to counteract the insulin resistance. And whether it is the number of cells or it is the functional capacity, we still don't know. We still have something doubt about the beta cell senescence effect, whether it does limit replication of the particular beta cells. But what is today's topic of interest or discussion is on the beta cell failure, which has a strong genetic component, reduced mass and dysfunction, and compromised beta cell identity. If you see the beta cell failure, there are 3 pathways of beta cell failure. We all know that this is islet of Langerhans, which has a center of the beta cells. Then we have alpha cells, which are shown in green, which are at the periphery, and we have delta cells, which are scattered all around. When there is a glucose response, or the glucose is presented to the beta cell, it secretes insulin. That's a simple physiology of understanding. Now, when does the beta cell fail? It is when you have a naturally smaller cell, beta cell mass, defective proliferation of beta cell, and eventually get reduced beta cell number. Or there can be what is called as the endoplasmic reticulum stress or oxidative stress, which is because of glucolipotoxicity, chronic inflammatory response, and adipokines, which are responsible for increasing the stress, and therefore the glucose is no more effective in producing the insulin secretion that we call a dysfunction of beta cell. And finally, there's something like a dedifferentiation of neurogranin 3, which means there's a loss of identity or a transdifferentiation of a beta cell. What you see in this picture, that you can see the number of beta cells have reduced. The red dots are reduced, but you can see the green dots have increased. That means the beta cells have lost their identity and got transdifferentiated or are dedifferentiated into alpha cells. And that is the compromised identity of the beta cell. And that is how we get the beta cell failure. We all know the type of diabetes is a complex genetic and a lifestyle interaction. We have obesity as a major driver for diabetes, and of course, sedentary lifestyle. There are many genes which play the role in the genesis of diabetes, but today's our discussion is on the pancreatic dysfunction. And these are the multiple genes we have: the beta cell development, the apoptosis, senescence, glucose sensing, and we have glucagon signaling and amylin toxin. These are some of the genes which are responsible for dysfunction and therefore having a beta cell failure. Now, if you look at the mechanisms, we felt that in the autopsy, when Peter Butler had seen that 50% of the beta cell is lost in all patients of diabetes. This is the autopsy study. The beta cell death, actually, there's very little evidence. Nobody has proven this, or it's difficult to prove even in the laboratory where there's evidence of a beta cell death. But what we know is definitely there's a failure to increase the beta cell mass depending on the age and therefore lack of proliferation. As one hypothesis is the early life environment which affects the beta cell proliferation. And that's how, with the people with the low mass and the chronic inflammation and chronic demand on the beta cell tend to have a decreased beta cell mass. And that's exactly what Barker hypothesis is the fetal origin of the adult metabolic disease. Then the environmental changes that occurs in the genes is actually called epigenetics, which actually refers to functional changes without alteration of nucleotide sequence. The epigenetics is a normal gene regulatory phenomenon involved in the human development, in the cellular differentiation, and each cell type has all kinds of genes. But the functioning human body tends to develop different cells in the body, like neurons and skins, depending on the genetic response. And finally, the several external factors can impact the gene function either positively or negatively. This is what actually it means, that we have the epigenetic mechanisms like diet, drugs, lack of activity or aging, which brings about methylation addition to the DNA. And also this is a spool on which the DNA is totally widely wound. And this histone modification will ultimately result into either a cancer or the autoimmune diseases or a mental disorders or diabetes. So therefore, this is how the methylation process of the DNA and the histone modification eventually results into changes in the phenotype of the gene. This is a very interesting paper which talks about type 2 diabetes as autoimmune disease. It's very strange. When we are normal, healthy individuals, the fat cells are normal. But in people who are obese, you can see number of fat cells have increased. And these increased fat cells brings about a lot of release of the cytokines, or what is called adipokines. And these adipokines affect the regulatory cells of the T cell regulation. And that brings about increased amount of CD4 and a CD8 cells. Normally, the regulatory cell maintains a balance between the inflammation and a non-inflammation, which is known as Th1 and Th2 pathway, which gets totally upset. And that brings about the autoimmune response and therefore the destruction of beta cells and therefore lack of insulin production and a lack of insulin regulation. So these are the features that we see in patients of metabolic syndrome and the inflammation and the immune tolerance and dysregulation. This was a presentation and NEGM, which looked at the beta cell dedifferentiation by the author, which is called Yuval Dor from Jerusalem. And what he says was, it's the beta cell loss is not because of death, but because of dedifferentiation, where the beta cells changes its identity and becomes into alpha cells, and that is called a dedifferentiation. Here, what was taught earlier that when you have the atmosphere, the surrounding with a high glucose or hyperglycemia, the beta cell becomes dysfunctional and the beta cell gets dead. This was the old concept. What we today believe that it is the dedifferentiation of beta cell. It is so programmed that instead of producing the insulin, it produces glucagon, and therefore this is a change in the function of the beta cell, which adopts the job of an alpha cell. And it's driven because of what is called as the FOXO-protein, which is a transcription factor. And once it enters into the nucleus of the beta cell, you get what is called these beta cells. Instead of producing insulin, they produce glucagon, they produce polypeptide and somatostatin. So therefore, there's a change in the function, and this is because there's a gain in function of the beta cells getting transferred into alpha cells. And this is what we have seen, that we have initially talked about the three types of these cells, that we said it was the polypeptide, it is insulin, it's glucagon. And what is very important is that there are also cells which are called E cells and G cells. And these are the cells which produce gastrin and ghrelin. It's very surprising. Gastrin normally is produced in the stomach, and this is also produced in the stomach. But what is the function of these two hormones in the beta cells? Well, we don't know exactly what is the function, but it was usually present in the childhood or in the infantile stage and disappears after the birth. So these are the fetal hormones which reappear in diabetes. Very interesting. These are hormones which otherwise normally disappear in birth, but they do reappear in patients of diabetes. Here you can see the human control, non-diabetic. Here you can see a patient of type 2 diabetes. Here you can see this red signal which talks about gastrin. So this is gastrin. And what is interesting is if it's exposed to high sugar, this is a rat experiment, where you can see it shows up gastrin, but the moment you bring down the sugar to lower levels, the gastrin disappears, saying thereby that the presence of gastrin in the islets of Langerhans is a reversible process. It occurs only in type 2 diabetes, does not occur in type 1 diabetes, interestingly. And what is another important factor is called the PAC6, which is again a transcription factor, which is the most important factor for the growth and the development of the beta cells. It is all dependent on the PAC6. And what happens in hyperglycemia is that the PAC6 gets suppressed. And because of suppression of PAC6, the insulin gene is also repressed. And what gets excited or stimulated is the release of glucagon, release of somatostatin, and release of ghrelin. You can see here that as soon as the PAC6 is suppressed, you can get elevation of blood sugar, and you can see the blood sugar and the insulin ratio is also changed. But what is very interesting is that you see the beta cells are disappearing, but the entire islet size has remained the same. There's no change in the islet cell mass. The islet cell mass remains the same, but only there is a transdifferentiation or dedifferentiation of the beta cell into alpha cells. So after having understood this, do you have any option to treat these patients? Whether we can use GLP receptor agonists, whether evidence of the regenerative therapies, which are not really very important because islet transplantation makes little sense because you require a lot of immunosuppression, which becomes difficult. And the best treatment could be to reduce the demand by doing a bariatric surgery where the insulin sensitivity appears as soon as you undergo bariatric surgery. GLP receptor agonist, this is an interesting paper, talks about the promotion of alpha to beta cell transdifferentiation. Here you can see that the glucagon-like polypeptide, when you expose the islet cells to glucagon-like polypeptide, you can see there's a change, and you can see that the alpha cells get converted to beta cell. And this change is brought about through the transdifferentiation. There's evidence, at least in animals, that there is a transdifferentiation. And this is the schematic representation of the same thing which I told you earlier, that it causes increased beta cell proliferation, increased beta cell neogenesis, decreased apoptosis. And that's how the GLP receptor agonists are a unique drug in improving the beta cell function. And just to remind you that one injection of GLP receptor agonist can improve the beta cell function in 24 hours time so quickly. What about SGLT2 inhibitors? Yes, It also has a protective action against pancreatic beta cells. There are several studies which talk about it. It improves the glucose toxicity and therefore has beneficial effects on the beta cell. It offloads the beta cells. It also takes away the insulin resistance, therefore decreases the ER and oxidative stress on the pancreatic beta cells. Lipotoxicity is also taken care, therefore improves lipid metabolism and increased production of ketone bodies also help these patients. Short-term intensive insulin therapy, this is the Chinese study, which looked at 358 patients. And here you can see here they were given either continuous subcutaneous infusion or a multiple dose infusion or the OHA. And what you see here, that within 2 weeks of treatment, you can see that the beta cell improved extremely well in patients who received continuous subcutaneous infusion. And even at the end of 1 year, you can see that the patients having improved beta cell function by initial intensive insulin therapy just for 2 weeks. So that 2 weeks of therapy improves the beta cell function quite significantly. Again, the origin trial looked at the same thing that you can see at 21 days and 100 days, patients of impaired fasting glucose or impaired glucose tolerance to conversion of type 2 diabetes. It was 30% in those who received insulin versus 35% those who did not receive insulin. And at the end of 100 days is again 30 to 35%. So you can get this kind of reversal of the patient's impaired fasting glucose to non-diabetic state by giving intensive insulin therapy. This is the Dallas study, which looked at the beta cell function preservation after 3.5 years. These are the 58 patients who received the diabetes treatment for first 3 months with the intensive insulin therapy. And subsequently, these patients were maintained in the oral drugs, and they checked the beta cell function at 6 months, 12 months, 28 months, and 42 months. And they could see that the beta cell function could last for at least 3.5 years with initial treatment with insulin for 3 months and subsequently oral hypoglycemic agent. Same is true when you treat lipotoxicity, and we have drugs like Metformin, which does improve the patient's signaling mechanism. TZDs are well-known class of the PPAR gamma agonist, which decrease the insulin transcription. And we have the adiponectin agonist, which also improve the function of the fat and therefore reduce the insulin resistance and improve the beta cell function. Weight loss is also a very important aspect to improve the patient's beta cell function. This is actually a window of opportunity, a very good study by Charles Buran, which looked at 58 participants with a BMI higher than 35. There are 14 patients with normal fasting glucose, 24 with impaired fasting glucose, and 20 with type 2 diabetes, and 13 were normal weight patients. And here these patients were studied for the beta cell function at 3 to 6 months, and some patients even at the end of 2 years. And here what weight loss? The weight loss was 20 kilograms. And what you see here, those with obese patients with impaired fasting glucose, look at the response even at the 2 years. At the 2 years also, they maintain the good beta cell function, which is not true in patients of type 2 diabetes. At the end of 2 years, they don't maintain the sensitivity. So therefore, patients who are obese with impaired fasting glucose, this kind of weight reduction can bring about remission of diabetes and have a good window of opportunity to treat patients of diabetes to improve the beta cell function. The great study, the last part of my talk, is the first H2A comparison between metformin and other medications. And idea was to look for the durability of control. And here we have 1,250 patients in each arm, either in glimepiride or sitagliptin, liraglutide, or glargine. And what do you see? That if you look at glargine, 67% of the patients did not get the A1C beyond 7%. That's a failure of control of glycemia. And same is true with liraglutide, it's 68%. But if you see, interestingly, sitagliptin had 77% and glimepiride at 70%. What it means is that the clear advantage for glargine and the GLP receptor agonist that kept the good metabolic control for significantly long period of time than glimepiride and sitagliptin. So to conclude the summary, the prolonged hypoglycemia leads to oxidative stress, ER stress, hypoxic stress, and cytokine induction, leading to beta cell compensation, stress, and later failure. We don't call death of beta cell, but it's a beta cell failure and a de-differentiation. Beta cell identity is fragile, but islet identity is stable. And islet cells share same chromatin structure and methylome. And other than hormone genes, they represent flexibility and plasticity states rather than the stable subtypes. FOXO plays an important role in de-differentiation and a redifferentiation of beta cells, and a reprogramming of other cells types to beta cell is a possibility and can be a potential treatment option for diabetes in future. As of now, GLP receptor agonist, SGLT2, TZTs, and metformin, and intensive insulin therapy offers some beta cell protection and preservation. With that, I conclude my talk. Thank you very much for the patient listening, and I stop sharing my presentation. Thank you. Thank you, sir.
Great. So, do we have any question or?
I think we can start with the second session.
Sir, I have one question, if time permits. So, what do you think the best combination or cocktail for beta cell preservation? As your talk was wonderful, almost you said everything, but I would like to know more from your clinical perspective.
Yes, I think the best combination, Ralph DiFranzo did a great trial on this, and he said, what could be the best combination that you can offer to the patient of diabetes so that you can preserve the beta cell for a long time? And according to him, the best combination is metformin, pioglitazone, and the GLP receptor agonist. If you have these three drugs on board, I think you can improve the beta cell function tremendously. And what was his study was that if you give GLP receptor agonist injection, the first injection improves the function of beta cell in 24 hours time. He has shown it convincingly that this can happen only with GLP receptor agonist. And now there's so much study on GLP receptor agonist on the beta cell preservation that because of paucity of time, I could not go in all details. But the beta cell neogenesis is a newer concept which has been documented in the lower animals and has shown to be effective in improving the beta cell function. There's one question of short-term insulin and diagnosis is a very useful intervention. I have achieved the remission in large number of patients. Dr. Arun KV, I think, yes, very good. If you can convince your patient to take intensive insulin therapy to begin with, it can bring about the remission. What actually happens is when they give intensive insulin therapy, you do not allow the FOXO protein from cytoplasm to go into the nucleus. The moment the FOXO protein enters the nucleus, the de-differentiation starts. The beta cell turns into alpha cells and therefore starts producing glucagon instead of insulin. That's why this intensive insulin therapy, which began as a Chinese study, is also a very important aspect of treating patients. The same I said as the Ldl study as well.
Great. So over to you, Pratap Jethwani, sir, for inviting our next speaker. I guess Dr. Pratap Jethwani is not here, I guess, with us. So our next speaker is Dr. Sunil Kota from Behrampur. His topic is getting basics right in improving outcomes for people with diabetes. Dr. Kota is a very good friend of mine and the king of memes on social media. So he's MD and DNB endocrinologist with FACE, and he's consultant endocrinologist at Diabetes and Endocare Clinic at Behrampur, Odisha. He has 89 peer-reviewed publications, 90 conference abstracts. He has 21 book chapters, ESI award for most number of publication in IJEM in 2012, best letter to editor trophy for paper entitled Endocrine Disorders in Tuberous Sclerosis at ESICON 2013. He has been selected as one among the 25 candidates across globe to participate in ISPAD Research School held at Boston in 2014. his CV is quite big. So over to you, Dr. Kota.
Thank you so much, dear Rutul, a good friend of mine, and very good morning to respected chairpersons, to the august audience, and thanks to the organizers for having me here at this prestigious event. I'm really missing Goa, but probably next time onwards. So just let me know once the slides are visible so that I can start. Is it visible to all?
Yes.
Yes, it is visible. Yes.
So my topic is to talk about getting basics right and improving outcomes for people with diabetes. You must be seeing that the introductory slide itself is very busy. I have been highlighting several societies, several guidelines, but then there are multiple recommendations, but we need to get the basics right. By saying that, what I mean to say is that you need to pick up things at the earliest and do the right thing at the earliest. Why should we do that? Because type 2 diabetes has impact on longevity. This was a wonderful article in Circulation 2019. You can see from the graph on your right, age at diagnosis defines the life years lost. Less than 20 years, 12 years life is lost. At the age of 45 years, if you are diagnosed as type 2 diabetes, 6 years are lost. And if you are diagnosed at the age of 65 years, still 2 life years are lost. This is followed by another article in NEJM which says at the age of around 50 years, you lose around 6 years of life. And if you talk about risk factors, more than 50% of people of type 2 diabetes have one or other risk factors like dyslipidemia, obesity, age more than equal to 55, hypertension, and smoker. Some are non-modifiable, especially the age factor, and most of them are modifiable. So we have to be miser in our expectation from anti-diabetic drugs. It should not only reduce the sugar, but should also give us relief as far as other risk factors are concerned. The complications of diabetes are known to us since ages. We have been taught by our teachers, seniors. There are microvascular complications. There are macrovascular complications. We have atherosclerosis, vascular remodeling, arterial fibrosis, all these things coming into the picture when we talk about the pathogenesis of vascular complications. So what about hyperglycemia per se contributing to macrovascular risk? This is a wonderful nurses' health study, a 20-year follow-up of more than 1 lakh patients. And what you can find is this gives rise to the ticking clock hypothesis, which says the clock for macrovascular disorder or cardiovascular disorder starts ticking much before the diagnosis of diabetes, and the relative risk of MI or stroke goes up by 5 times if you have diabetes at the baseline. And not only that, this was another article in Lancet 2010, which has taken the data of around 7 lakh patients, the emerging risk factor collaboration, and you can see all these parameters, the coronary heart disease, cerebral vascular disease, and other vascular events, all of them are actually going up by 2 times when you have diabetes. If you talk about some other registers like Swedish National Diabetes Register, again, a staggering 4.5 lakh patients, and look at all the 3 parameters, the death from cardiovascular disease, death from coronary heart disease, hospitalization for cardiovascular disease, all of them, they go up 2 times. And the Asian Indian phenotype, we all have been talking a lot. Then this is the retrospective analysis of J-DREAMS, which was done on Japanese people. And they have tried to look at the number of permutation and combination that are feasible when a person is having type 2 diabetes, especially in cases of Asians. And you can see, I'm not going to read out all those for you, but there is a number of permutation and combination which can come to the fore. And look at the percentages, the obesity, type 2 diabetes, dyslipidemia, CKD, and there are bidirectional association between most of these conditions. And multiple comorbidities also dodge the Indian phenotypes. They have greater degree of central body obesity, higher insulin resistance, and characteristic dyslipidemia. And recent few studies have come up which have shown that the beta cell dysfunction sets in quite early in Indian subjects. And when you have these comorbidities in combination like hypertension and abdominal obesity, you are at a 2-fold risk of cardiovascular and a 40 to 70% increased risk of renal complications. So therefore, now that we know what are the things that have been dodging the Indian type 2 diabetic patients or the patients having diabetes, we need to screen patients appropriately to detect complications early and to prevent further degradation. We know, we have been taught by our seniors. I am sandwiched by 2 wonderful speakers, Vijay sir and Benny sir. Benny ma'am, yes, we know that we need to screen, but then look at the International Diabetes Management Practical Study, which says that For cardiovascular disease, 20% of type 1 and 16% of type 2 diabetes have never received screening. For retinopathy, 9.5% of type 1 and 20.5% of type 2 diabetes have never received screening. And for microalbuminuria, 23.2% of type 1 and 36% of type 2. And similarly for neuropathy, 18% of type 1 and 26% of type 2 diabetes have never received any screening modalities. If you talk about Indian data, probably the numbers would again swell up to unimaginable numbers. And these are the screening recommendations. As I've already started by stating that we need to pick up things at the right time. And how do we pick up? These are the screening mechanisms. So retinopathy, type 2 diabetes at the time of diagnosis, type 1 diabetes within 5 years of diagnosis. And when exactly do we repeat it? If in one or two examinations you find there is no retinopathy, you can do it once in 1 to 2 years. If there is presence of due to progressing retinopathy or there is sight threatening, you have to measure it more frequently. If there is some sort of retinopathy at the outset itself, you have to measure it annually. The peripheral neuropathy, you should be screening at the time of diagnosis and then onwards annually. And foot, which bears the brunt of the disease, has to be screened at each and every visit. And diabetic nephropathy, the creatinine and EGFR at the time of diagnosis. And the albumin creatinine ratio, unfortunately, is being missed by many of us. Type 1 diabetes, it should be done in people having duration more than 5 years. Type 2 diabetes at the time of diagnosis. And if it is normal, measure it annually. If it is high, within subsequent 3 to 6 months, do it 2 to 3 times. If more than 2 values are more than 30, you have to treat it. Otherwise, we screen annually. What about the cardiovascular disease screening? In asymptomatic patients, it is a big no. It should be considered for patients having coronary artery disease in presence of any of the following, like atypical cardiac symptoms, signs or symptoms of associated vascular disease, including carotid bruit, transient ischemic attacks, stroke, claudication, or peripheral arterial disease, or if there is any electrocardiogram ECG abnormalities. What about children in adolescents? Slide again looks busy, but I'm going to sum it up by stating that you should be screening the presence of thyroid disease, celiac disease, hypertension at each visit, and dyslipidemia soon after diagnosis. But when you talk about nephropathy, retinopathy, and neuropathy, it should be checked at puberty or more than 10 to 11 years old, whichever is earlier, and diabetes duration of 5 years for nephropathy and neuropathy and 3 to 5 years for retinopathy. We should not be missing the persons who are at extreme need of our care, the older adults. We should be doing an assessment of medical, psychological, and functional and social domains, and we should be able to judge their ability to self-manage and what about the quality of life. And neurocognitive function always takes a backseat. But the ADA states screening for early detection of mild cognitive impairment of dementia should be performed for adults 65 years of age or older at the initial visit and annually as appropriate. Now that we picked up the things, we should be all proceeding the treatment. What should be done? After that wonderful talk by Vijay sir about the beta cell preservation, my talk would be easy, but we all know that this is patient-centered approach. We should gauge the patient preferred level of involvement, and there should be a shared decision-making. We have come across conferences on mind-body medicine. How do we communicate with compassion and empathy to the patient? And what is the impact of these 3 parameters, the blood sugar, blood pressure, and lipids? We all know for microvascular complications, there is a linear relationship between blood sugar and the complications. But whereas the macrovascular complications, yes, the blood sugar is important. But apart from that, the STENO2 study clearly tells us that the blood pressure, blood lipids, and other risk factors are also supposed to be taken care of. This one is in Lancet 2009, which says the impact of each of these interventions. The systolic blood pressure reduction, the LDL cholesterol reduction, and A1C reduction, their impact, and the best one is the systolic blood pressure. I would quote one just interesting question from Professor Bhansali during our endocrine residency days. Hyperglycemia is predominantly contributing to peripheral arterial disease. Hypertension is contributing to predominantly cerebrovascular disease, and dyslipidemia is predominantly contributing to cardiovascular disease. But for complete control, you need to have all these under check. We know A, B, C goal, we have been taught several times, but to improve the outcomes, these are the parameters, but only 18% of people achieve those A1C goals, A1C of less than 7%. This slide, we must have seen n number of times, but again, it reiterates the fact that glycemic control is very, very important as far as microvascular disorder is concerned. And some of the long-term studies like the UK PDS and the EDIC study have also told us about its importance as far as cardiovascular disease reduction is concerned. And again, just to tell that glycemic control is equally important for reduction of microvascular disease states, risk of CV death, non-fatal MI, non-fatal ischemic stroke. You can see the parameters which are important at the A1C, the LDL cholesterol, and the systolic blood pressure. So what about the glycemic targets? Non-pregnant adults less than 7%. And nowadays we have this time in range, which should be more than 70% of the time the blood sugar has to be within the range. If a person is younger, has long life expectancy, and has no cardiovascular disease, he can be given a more stringent A1C target without any hypoglycemia. On the contrary, an elderly person, short life expectancy, and conditions predisposing him to have more of hypoglycemia, goal of up to less than 8% is also appropriate. Anti-hyperglycemic therapy, the lifestyle at each and every stage. Recently, I came across a Cochrane meta-analysis which says that the lifestyle intervention at any stage does give rise to benefit as far as metabolic and your other health is concerned. Oral agent, non-insulin injectables, we all know, but then, and the insulin is also important. And as far as beta cell preservation is concerned, we learned from Vijay sir about the incretin-based therapies, the short-term insulin therapy, DPP-4 inhibitors, and also SGLT2 inhibitors. So therefore, the ADA 2022 clearly tells us that, yes, metformin is the first line of therapy, but if you have any of the high-risk conditions like ASCVD or high-risk or heart failure or CKD, you have to pick these wonder molecules. Those are the SGLT2 inhibitors and the glutides, which are the GLP-1 receptor agonists. And we have a few more in the kitty, like the oral semaglutide, which is launched recently, and the tirzepatide, which is the quincritin analog, which got approved very recently. And there is also this trial Amplitude O, which basically tried epiglinatide, which is a GLP-1 receptor agonist, in combination with SGLT2 inhibitor, and this combination was doing actually wonders. Very importantly, we should not be missing the quality of life issue, because care with compassion and language matters, as I've already stated. More the patient is satisfied, the greater is the medication adherence and the better quality of life, because it is a lifelong therapy. So we need to take the patient into confidence and increase his confidence on the treatment that we're giving. And there are some QL scores, the DAWN score, the SF12 score, which can be used, and lesser number of medicine is always welcome. And the last point, which is the sixth point, I derived it from one of the studies by Dr. Manas Barua from Assam, who stated that insulin along with OHA gives rise to better compliance with, as far as diet is concerned, and enhanced quality of life as far as, because of their better diabetes related knowledge. What about the blood pressure? A number of mechanisms are interlinked. We are repeatedly asked during our student days how it can be co-associated. There is sympathetic overactivity, the RAS activation, kidney sodium retention, vascular and inflammatory mechanisms. A number of, when these two conditions coexist, you have a number of mechanisms in place which can push the patient towards more of macro and microvascular disease. And this study, again, we have been seeing number of times, CNEGM 2005, diabetes and hypertension versus diabetes, there is a significant increase of coronary heart disease, stroke, retinopathy, nephropathy, neuropathy, and mortality. And on top of that, we have also studies which tell us that with each 10 millimeter reduction of systolic blood pressure, all these parameters go down significantly from 9% to 27%. So what about the hypertension in type 2 diabetes? More than equal to 140/90. Whenever a patient comes to you, the blood pressure should be confirmed with multiple readings, including measurements on a separate day. And all hypertensive patients should monitor their blood pressure at home. How do we treat? More than 140/90 and less than 160/100. If there is albuminuria or coronary artery disease, you have to include ACE inhibitor or ARB. Other than that, you have any of the drugs like CCB, diuretic, ARB, and ACE. When the blood pressure initial is more than 160/100, you have to think of the combination therapy. Of course, one among them should be ACE inhibitor or ARB if there is presence of albuminuria or coronary artery disease. Lastly, the cholesterol parameter, the Indian dyslipidemia, again, we have been talking about a lot. High presence of high degree of low HDL, high triglyceride, small dense LDL goes up, females outnumbering males as far as the prevalence of dyslipidemia is concerned. And this article has tried to change the way we look at it. We should not be looking at the fasting lipid values in majority of the cases. So you can go for the non-fasting lipid values at the outset itself. And lipids, as far as lipid is concerned, Below 40 years, it should be done at the initial medical evaluation and every 5 years, because above 40, we know that the guidelines tell us that moderate intensity statin has to be given anyhow. And once the statin is initiated or any other lipid lowering therapy is initiated, 4 to 12 weeks after initiation or change in dose and annually thereafter has to be done. LDL cholesterol, the LAI goals, very high risk less than 50, high risk less than 70, moderate risk less than 100, and low risk less than 100. Non-HDL cholesterol is something which is again very, very important. These are indicated by two different programs. First of all, the NCP ATP3 says that non-HDL cholesterol is a secondary target with a goal of 30 milligram higher than the identified LDL. But LAI, the Lipid Association of India, says the non-HDL cholesterol is a co-primary target, and it asks us to achieve the LDL cholesterol target first. If TG is still above 200 milligram, calculate the non-HDL. If above goal, add a non-statin drug to achieve the non-HDL cholesterol goal. And not only that, we have to look at the other risk factors. The smoking, we know the retinopathy, the microalbuminuria, macroalbuminuria, all of them, they go up as per this Eurodive IgDM complication study. And yes, the smoking is associated with 70% increased risk of diabetic neuropathy. Alcohol again is very much significantly related to microvascular damage, and 33% excess cause or death can be caused due to alcohol intake. It can give rise to fluctuation in blood sugars. It can enhance the complication. It can also induce a state of acidosis. And look at the impact of smoking on the diabetes complication. Number of those: total mortality, cardiovascular mortality, cardiovascular disease, coronary heart disease, stroke, PAD, and heart failure. Lastly, infective disorders are also to be looked at carefully, because these are the days when we were talking a lot about corona and diabetes. So we have to prevent these disorders like pneumococcal vaccination, influenza, tetanus, diphtheria. This is the article which was published in IJM 2012 that I've quoted. But then the pneumococcal flu, these are the basic ones which we all should be trying to inculcate in our day-to-day practice. A good complication-free life. So to summarize, predominantly the vascular complications are to be tackled. The blood pressure, the blood sugar, the lipids, and other risk factors like smoking, the alcohol have to be taken care of. And apart from that, periodic screening for all these complications as per the existing guidelines should be done, so that these can be picked up early, and there are effective interventions which can actually help us get them back to total normalcy. And we also need to be alert for emerging risk factors like anemia is there for anemia is a risk factor for diabetic nephropathy. Family history again is a very strong risk factor for diabetic nephropathy. So all these factors have to be taken into consideration when we try to treat the patient holistically. Thank you all for the patient listening. Over to the chairpersons.
What a wonderful talk, Dr. Kota. Indeed, you were one of the important part for screening and Defeat Diabetes campaign, and you have done a wonderful job. If we have any question, we can address. I guess if we don't have any question, we can move further for the next talk of Dr. Benny Neglur, ma'am. So can I have the CV? Yes, Dr. Benny Neglur is MD and FACE FSCP. She is director of Dr. Neglur's Diabetes and Thyroid Specialty Center, consulting diabetologist at Jupiter Hospital, Thane, fellow of American that FACE. She is also have FSCP and Indian College of Physicians. She is teaching faculty for fellowship in diabetes for D.Y. Patil University, teaching faculty for PHFI, and founder, president, and organizing chairperson of WODCON, Women and Diabetes Conference, since last 5 years. Over to you, ma'am, for your talk.
Thank you so much. Thank you so much, Dr. Rutul. And we've heard two wonderful lectures today. And let me just share my slides. So I'll make it full screen. Yes. And now we are coming to the topic of, are we missing or practicing evidence-based practice in diabetes? We know that there's so much of new discovery. Every day we are getting so many updates, and for which we have to attend the CMEs and we have to attend conferences like this, because there will be some update every month or every day. And this new data has actually led to important advances in our understanding of type 2 diabetes, the mechanisms, and all the other aspects, how the drugs work, etc. Interventions to increase exercise and reduce weight and control the elevated glycemia and the blood pressure and cholesterol levels demonstrated a significant decrease in mobility and mortality. But in spite of all this, we are not successful in lowering the burden of diabetes, in lowering cardiovascular complications, in lowering microvascular complications, in improving the glycemic status among diabetics, and in improving lifespan. So we are missing something. And that missing link is the inability to effectively and widely translate the clinical evidence into usual practice, and that is a major shortcoming of modern medicine. So are we missing evidence-based medicine? Yes and no, and maybe as well. Evidence-based medicine was always there, but at that time they used to have practice-based evidence, and that worked. You see, as early as 25 AD, careful men noted what generally answered the better, and then began the same for their patients. And as early as 1900, so careful observations were clearly recorded and a deductive reasoning was made. And these were case-controlled studies and observational data. But their causality was not known. There was a personal bias, and this was done in isolation by only few practitioners who had a good eye for all new things that happen in the patient, the new clinical symptoms, etc. Confounding causes were not found, and there was something known as a Procrustean bed, where you actually make a diagnosis and then fit in your clinical signs and symptoms, just like Procrustean did. He didn't have a long bed, so in very tall people, he would cut off the legs and fit the patient into the bed. So we should not do that. And to address all these issues, you required a framework and rules to utilize this evidence in a very systematic manner. And that's how evidence-based medicine took birth. So we had, over the number of years, RCTs, we had meta-analysis, systematic reviews, cohort studies, case-control studies, observational studies, views, expert opinions, and so on. But then we have so much data, we really don't know what to do with all this. We had to pick up what is essential and good, and we have to discard what is not essential when we practice medicine. So if you look at all this strength of evidence, systematic reviews and meta-analysis of the randomized controlled trial have the best quality of evidence and the least amount of bias, because they collect all the data from several RCTs and then give an outcome as to what is the benefit or the risk of all these studies, looking after their inclusion criteria, exclusion criteria, and the various outcomes that they get. And then lower down in this pyramid, we have cohort studies, we have case-control studies, cross-sectional case reports, and last of all, ideas, opinions, and reviews, of course, which are individualized. So we will always look at the hierarchy. Hierarchy is a rock on which evidence-based medicine is built, and this has various levels of evidence. So RCTs or meta-analysis, where the lower limit of confidence interval for treatment effect exceeds the minimal important benefit, has the highest level of evidence. RCTs or meta-analysis which have the lower limit of confidence interval for treatment effect overlapping with the minimal important benefit benefit is level 2. And then you have level 3, level 4, and level 5. And this hierarchy actually has had so many revisions since the last few years. So we know what evidence-based medicine is, and we have so much of data. But when it comes to practice and when it comes to clinicians, are we translating this evidence base in our patients, or are we missing the evidence-based practice from all the data that we receive? So there is a translational block here, and the first block is to convert the research to a given patient that we see in our practice. We cannot take everything from the bench and put it on the bedside. And the second translational block is that we need to convert the evidence that we have into practice. And to do this, we need to have, besides the clinical research and the data that we are getting, we need to have clinical experience. And you know that the senior doctors and juniors, or those who have a vast practice, have tremendous clinical experience. You need to combine that with the evidence and also look at the patient's preferences. I think this is the most important when we need to practice. You have to look after the quality of life of the patient. You have to also see whether the patient can afford the therapy that you're giving. And there are so many preferences that patients like, and they say, like, please don't give me tablets 3 times a day because I'm at work and I cannot take the tablet in the afternoon. Please give me morning and evening. This is what the patient prefers, and we have to adjust our treatment to the patient's preferences as well. And if you combine this clinical research, clinical experience, and the patient's preferences, then it will be easy for us to use this data and evidence and put it into practice. So, and why do we get these translational blocks? Because people are not statistical programs that will behave identically. We are all complex individuals. We have our own problems. And just because something worked in a particular population does not mean we should do the same thing to another group and say we have evidence for that. This is very important. But there are benefits of evidence-based medicine when it is properly applied. And these are obvious. So I took a simple example of Metformin. You see, the UGDP trial, the University Group Diabetes Program Study, which was done in 1970s and presented in 1971, actually said that all the OHAs that were used at that time increased cardiovascular mortality and death. They should be banned. You can only use insulin for the patients. And especially referring to Metformin, cardiovascular and total mortality in adult onset diabetes treated with Metformin was significantly higher than in patients treated with insulin or with placebo. And you know the effect of this. So Metformin, Fenformin also had the increased incidence of lactic acidosis. And somewhere in 1978, you know, that Fenformin went out of the market. And in USA, they took out the Metformin also from there. But all of us here in the Asian countries and in India, we were using Metformin ever since the UGDP and much before that. And it was only USA or the FDA that approved it 20 years later for reintroduction into the guidelines. And that was because of the UKPDS study. In fact, this is the data that turned tables. And the UKPDS actually showed that there's a 39% decrease in myocardial infarction. There's a 42% increase in diabetes-related deaths, and any diabetes-related endpoint was decreased by 32%. And therefore, Metformin came back in USA, and we know that now it is the ACE and used in all guidelines as the first-line therapy. Again, using the evidence where it has made a big change was in rosiglitazone. 2008, it was Stephen Nissen who did a meta-analysis, which has the highest level of evidence, and said that rosiglitazone increases myocardial infarct and death from cardiovascular causes. And we know what happened to rosiglitazone. It went out of the market. We are still using its brother, pioglitazone, keeping in mind that a meta-analysis also showed that pioglitazone was associated with the risk of blood cancer. This is a black box warning. And then with all this evidence, came the guidelines, and the guidelines are changing every year, not drastically, not producing a big paradigm shift now, but there's a consensus between the ADA and ESD, and we have our RSSDI guidelines as well, which we have to keep on updating with the new data that we get in. And this is where data helps. This is where evidence helps. And we know that although the guidelines have to be implemented because of the evidence that is available, India is still lower down. The prevalence of diabetes in India is 8.3. Every 9th person has diabetes. The number has gone up to more than 78 millions. And we know that there's a huge economic burden on patients and the government of India. So are we missing evidence-based practice? We know that in spite of standardizing and disseminating evidence-based guidelines, this is the study that we got very recently, 2019. It is a real-world evidence of glycemic control among patients with type 2 diabetes mellitus in India. The TIDE study shows that nearly 76.6% of patients had uncontrolled glycated hemoglobin, more than 7. So you see the number of patients who are controlled is only a fraction, just about 23% in India. So we are missing something there. Again, we are looking at the guidelines here and seeing the patients on CV risk. We know that GLP-RA, SGLT2 inhibitors have to be given to patients with high ASCVD risk or with CKD. But is it happening in our country and elsewhere? Only 1 in 20 patients were prescribed evidence-based therapies, SGLT2, GLP-RA for diabetes mellitus. And I want to stress the word prescribed. So the inertia is coming from the practitioner himself or herself, and appropriate treatment is not selected based on background risk factors or comorbidities. This was presented just this year in February 22 in JAMA, where they saw the use of lipid, blood pressure, and glucose-lowering pharmacotherapy in patients with type 2 diabetes with atherosclerotic cardiovascular disease. And continuing this further, another study done in India, a systematic review, said that the cardiovascular diseases and its risk factors are increasing with a rapid pace in Asian Indian population, and especially in India. And we know that this rapidity of increase is more not only in the urban population, but also in the rural population. And we have a huge rural population in India, and this may lead to epidemic proportions. So we need to intensify this evidence-based goals and of control of diabetes to prevent the cardiovascular risk. What about glucose monitoring? SMB is generally recommended, but is it properly followed? You see this survey done by the International Working Group for SMBG in 2008, and they found that the lowest use of SMBG was found in India, 0.2%, which is very disheartening. And even if those who are doing the SMBG, you see, they just tell you that today's sugar was 200, and 5 days ago it was 300, and before that it was 120. So you see, you have trouble spotting the pattern. Like in this figure, it is done at a random way without any structured process. Even the continuous glucose monitoring, ADA 2021 updated standard says that we have to look at time in range and time below range, and we have to include CGM for all patients of diabetes who are taking insulin once or more than once a day. But currently, what is the situation? Less than 1% of insulin requiring patients are using CGM. So we are lacking somewhere. We are not using the innovative informatics, population-based perspective with accurate linkage of patients to corresponding providers. We are not using the applications that save physician time rather than create more work. And we are not having effective methods of improving care independent of clinical visits. So there is a requirement for this. Look at insulin. Those who are on insulin, 1 in 4 patients stops taking insulin in the first year itself. So there are high dropout rates, and they give very lame excuses. My body tells me that without testing my blood sugar, I can make out whether it is high or low, or doctor doesn't need to know my sugars because he's looking at the HbA1c, etc. So behavior has to be changed. Patient counseling is important while initiating insulin, and also monitoring has to be enforced. Closed loop insulin pump. This is a well-established therapeutic options used, especially in type 1 patients, but we are lacking there because of affordability, of maybe accessibility, or even the need to create professional training is absent in India. So although we are practicing diabetes for that many years, maybe we are several of us are not been trained for the pumps. And are we doing enough for GDM? So you see here, worldwide, 1 in 10 pregnancies is associated with diabetes, out of which 90% of them are GDM. Pre-diabetes and diabetes affect approximately 6 million births in India alone, out of which 90% are due to GDM. Only half of these women are tested postpartum for GDM. And there is absolutely no consensus as when the woman has to undergo an oral glucose tolerance test and when they should come for follow-up. Even the patients, even if they are told, they do not come for follow-up, because this, if you attack the epidemic at this level, it will produce a big change in the prevalence and the increase in diabetes. There is clinical inertia here. It's an important barrier for evidence-based practice. And primary care physicians, although they acknowledge the existence of clinical inertia, they might find it quite insulting if you tell them that. So we have to involve patients directly in their care, and that is missing in our practice. Guidelines encourage the involvement of patients into decision-making and diabetes care. But look at the ICMR INDIET study. Only 43.2% of the overall study population had ever heard about a condition called diabetes. And we are missing the measure of diabetes education of clinical practice, although the ADA recommends that diabetes self-management education is necessary to provide information, skills, and competences for diabetes patients. And look at the findings in the Northern India study. 25.5 patients were non-adherent to anti-diabetic medications. 29% were non-adherent to dietary recommendations, and 52% were non-adherent to exercise recommendations. So high-quality diabetes care through primary care clinics and the physician is a major public health challenge in the developed world. So if we all agree upon the best practices based on data and research, we can reduce unnecessary care, save money, and push people into pathways to yield better results. Only thing which I want to stress, and the message should be passed today, we should know what to do with what we learn. Just like this picture here, we trust so much in data. And look at the study that was done. What's freaking us out here is that we found a correlation between owning cats and being struck by lightning. I think there is a lot of unnecessary data. So we should know what to do with what we learn. And this is very important. So in conclusion, I want to say that evidence-based medicine is very important. We need to have more and more data, because this data is helping us to have to decrease complications and also helping us to kind of decrease the prevalence of diabetes. The only thing is that it is not put into practice. We have to choose what we need to learn and translate what is important to the patient at all levels, in the rural and in the urban areas, and at a community level. No single best practice is appropriate for all patients and practitioners. You have to tailor to patients and customize to settings, and this is absolutely necessary. Real world translation requires flexibility to deal with pragmatic issues such as provider time, constraints, reimbursement, and system problems. Thank you. Thank you very much. Stop share.
That was really a wonderful talk, ma'am. So, do you see any difference since last 5 years? Though evidence practice is improving, I would say we had data that it is not that encouraging. But after so many movements like RSSDI and Diabetes India, the way they have done tremendous job. And you senior doctors have shown us the path, how to treat the patient and how it should be evidence-based treatment. So do you really see the difference in last few years that we are changing? Like SMBG, the data we saw that only 5 to 6% of the patients only doing SMBG. What do you think really?
Coming to your last, I think, point, SMBG, yes, what you are seeing, Dr. Rutul, is only in the urban areas and in the cities where we are practicing, where SMBG is done quite frequently, and we insist this. But if you take the whole of India and you take the rural areas, SMBG is hardly done. And if it is done also, they do not even show it to you. Yes, in the last 5 years, there has been tremendous evidence now, and there was a paradigm shift 3 years ago in the guidelines itself. And I think India is doing a good job for all these conferences, and there are many conferences and CMAs held in various regional areas of India and at all levels, even going down to the general practitioners. But maybe it is not, we are missing this evidence base because there are so many patient preferences. There, as I told you, one example, patients come and tell you, I don't want to take insulin. Evidence says that you have to initiate insulin, but they say no. If you do not see their preference, they will change the doctor. Isn't it? So that has to be the first criteria. We have to look at the quality of the life of the patient other than using every evidence that we get in evidence-based practice. And also all that evidence that we are getting may have a lot of bias, because it is the pharma industry that generally sponsors these trials. I mean, they have to, and that's why the trials and studies are done. And you see evidence of 2/3 of the trials and studies are pharma-based. And so there could be a lot of bias as well in these studies. And when we see a given patient in front of us, we can actually realize this bias, but we need to take the expertise or your experience of the doctor. You need to see the patient preferences and then use this evidence, which we are learning now at all the conferences all over the world, use this data to the benefit the patient.
Thank you, madam. Sorry for that. I was not able to log in because of some technical issue, but excellent deliberations by Dr. Vijay Neglu, Dr. Sunil Kota, and madam yourself. So I would like to ask one question to Dr. Vijay Neglu. Sir, any impact of diet, the macronutrient composition, particularly carbohydrate and fat, as far as beta cell function is concerned, whether high carbohydrate diet has got bad effects or high fat diet has got bad effects?
Yes, I think a good question. There's recently a study which was done looking at more than 130,000 patients in 27 countries. And what was the conclusion? To make the long story short, that it was the carbohydrate which was the principal driver of all the cardiovascular events. And what was the interesting part of the study was, if you look at the fat, whether it's a sat fat or a monounsaturated fatty acid or a polyunsaturated fatty acid, PUFA, it did not contribute to the cardiovascular disease as much as carbohydrate contributed. So real problem in the diet is the carbohydrate. So therefore, if you cut down the carbohydrate to just 40% or below 40%, then I think you can manage your diabetes well. But we all know in India, we have more than 65% of the food content is by the carbohydrate. So you're right that the carbohydrate restriction does play an important role. And fats, as it was maligned to be a bad kind of a food substance, is not true. And this is the very much important evidence that we got recently. And this was one of the best paper in 2017. There were the maximum hits on this paper.
Thank you, sir. I would like to have a take-home message from all three of you that how to blend the evidence base which is there into a real routine clinical practice so that we can provide better treatment to our patients and improve their outcomes. All three of you, Dr. Sunil, Dr. Neglu sir, and Madam you also. So I will start with Madam first.
Yeah, we'll be,
yes. Okay, so as I told you, my punchline for my lecture was, you have to be abreast with all the evidence and all the new data that is coming in, but you have to know what to do with what you learn. If we do not know and translate this to the patient, then we are not doing justice. My punchline is, you have to know what to do with what you learn.
Yes, sir. Naglur, sir, your view.
Yeah, I think Madam is right. And she has actually summarized everything that anyone else can say. I feel evidence-based medicine is important because that is a real guiding force to treat the patient. But sometimes the evidence also has to be looked very carefully. You need to read between the lines and therefore see that the evidence is applicable to certain part of the communities. What is applicable, for example, if you look at ACE inhibitors, the ACE inhibitors do very well in Indian patients, but they don't work well in the Africans. If you look at the DP4 inhibitors, they work extremely well in Asians, but do not work very well into the Americans. For example, I showed the GREAT trial. In the GREAT trial, amongst all the drugs which they studied, the sitagliptin was the worst drug in terms of maintaining the patient's glycemic control at the end of 5 years below 7%. But the other drug, for example, even the sulfonylurea was better. So therefore, all these evidences are depending on where the study is done and how the study was done. And we need to understand the methodology, how they derive the conclusion, and then use it very carefully. So you should mind your P's and Q's correctly to use the evidence to treat the patient sitting in front of you. And therefore, it's important you should not use the round peg in a square hole. If you do that, then more often than not, you are in the wrong side and the patient is not happy, nor you are happy.
Very well said, sir. Dr. Sunil.
Sir, he's not here. He just left and messaged me that he can't.
I think Rutul, we can conclude now. It is 12:15. Thank you very much. All the faculties, Dr. Benny Naglur, Madam, Dr. Vijay Naglur, sir, and Dr. Sunil Kota for excellent deliberations. And thank you, Diabetes India, Dr. Bansi, Dr. Manoj, Dr. Arvind, sir, Dr. Amit, and the entire team for inviting me and Rutul to chair these sessions and to be part of this excellent academic extravaganza.
Thank you. Thank you very much, Pratap. Thank you very much, Rutul, for conducting the session very efficiently.
Thank you.
So that brings to the end of first session. Thank you, chairpersons. Thank you, speakers, for a wonderful session.